Today we are going to understand body's response to metabolic stress, which is also very important when determining optimal timing and type of nutrition intervention for the patient. What is preoperative nutrition and nutritional needs of surgical patients? The nutritional needs of surgery patients vary based on several factors. These multiple factors include patient's disease process, comorbidities, and baseline nutritional status. Many general surgery patients are adequately nourished preoperatively and do not have any special nutrient requirement. The disease itself lends to poor nutrient intake and a hypermetabolic state that places the patient at nutritional risk. Malnutrition is associated with altered immune functions, poor wound healing, and increased morbidity and mortality rates. More than 50% of hospitalized patients are malnourished on hospital admission and hospital discharge. For optimal outcome, a malnourished patient should be nutritionally repleted for 7 to 10 days before surgery, if time permits. Unless the gastrointestinal tract is non-functional, nutrition provision should be provided enterally rather than parenterally. Adequate calories should be consumed to prevent the loss of endogenous stores of carbohydrate, fat, and protein. Carbohydrates should constitute the majority of calories, which is round about 50 to 60%. A minimum of approximately 150 gram of carbohydrate per day is needed for central nervous system function. Most proteins do not have excessive preoperative protein requirements, but body stores should be assessed. Adequate protein status is imperative to facilitate optimal wound healing. Any deficiency state, such as anemia, which is should be corrected, electrolytes and fluids should be normalized and in balance with correction of dehydration, acidosis, and alkalosis. Another factor is the use of medicinal herbs. Many patients do not think to disclose the ingestion of herbal supplements when they are asked about medication during the preoperative interview. But some of these substances can complicate surgery. There are some physiologic changes related to the aging process that can affect surgery. These physiological changes include decreased elasticity of blood vessels, which affects the decreased circulation to vital organs. Its potential post-operative complication will be shock, thrombosis with pulmonary emboli, delayed wound healing, post-operative confusion, hypervolemia, and decreased response to stress. And other physiologic change is decreased elasticity of lungs and chest walls, reduce residual lung volume, which decreases the vital capacity, gas exchange, and cough reflux. And its potential post-operative complications will be pneumonia, post-operative confusion. And other physiological changes is a decrease in glomerular filtration rate and bladder muscle tone, which decreases the kidney functions, stasis of urine in bladder, and loss of urinary control. And its potential post-operative complications will be prolonged response to anesthesia and drugs, overhydration with intravenous fluids, hyperkalemia, urinary tract infection, and urinary retention. Other changes include decreased muscle strength and limitation of motion, which decreases the activity, and complications should be pneumonia, thrombophlebitis, constipation, or fecal impaction. And other changes is decreased intestinal motility, which retention of feces, and its complication will be constipation or fecal impaction. Other is decreased globulin level, plasma proteins, and decreased response to foreign antigens, which decreases the inflammatory response, decreased ability to protect against invasion by pathogenic microorganisms. And its post-operative complications will be wound infection, wound dehiscence, pneumonia, and urinary tract infection. Typical dietary preparation for surgery involves giving nothing by mouth 8 to 12 hours before surgery. The rationale is to ensure the stomach is empty of food and liquids to prevent vomiting or aspiration during surgery or anesthesia recovery. In an emergency situation, gastric suction is used to remove the stomach contents. With surgery involving the GIT tract, food and fecal matter may interfere with the procedure itself and cause contamination. Before lower GI surgery, a low residue diet may be prescribed to reduce fecal residue. Restricting dietary intake may decrease the risk associated with anesthesia. It can also impair the patient's ability to respond to the metabolic stress of surgery. To reduce surgical stress and post-operative complications, the use of an enhanced recovery after surgery protocol is important. Nutrient provision in the post-operative period depends on basically several factors, which including the surgical procedure performed and anticipated, time to resumptions of oral intake, complications of surgery and post-operative clinical status, and preoperative nutritional status. The well-nourished patient elective surgery will typically resume oral feeding by post-operative day 3 to 7, which is basically depending on return of bowel function. Supplemental nutrition in the form of enteral and parenteral nutrition is not indicated. The malnourished patient who is undergoing elective or emergency surgery and not anticipated to be able to meet his nutritional needs orally for a period of 7 to 10 days should receive specialized nutrition support. This nutrition support should be provided enterally rather than parenterally to minimize incidence of complications. Basically, post-operative nutrition duration of this therapy will depend on the patient's status. Patient's basically clinical status. What will be the clinical status of the patient and transition to an adequate oral dietary consumption. In the immediate post operative period, especially in the critically ill, The goal of a nutrition sport is maintenance of current lean body mass and should serve as an adjunct to other critical therapies. Numerous factors are present that limit the effectiveness of exogenous administered nutritional substrates in the preventing catabolism regardless of the level of sport. It should not be expected to convert a catabolic into an anabolic state at this time. Many undesirable metabolic complications can occur in attempting to do so, such as hypercapnia, hyperglycemia, and hypertriglyceridemia. Multiple methods are available for determining the energy requirement. Indirect calorimeter involves actual measurement of energy expenditure and remains the gold standard. Many disadvantages to this method exist, including increased cost, the potential for improperly trained personnel, inaccurate readings in patient with the fraction of inspired oxygen. Predicting energy needs can be difficult because of uncertainty regarding multiple factors of energy expenditure. Predictive equations may overestimate energy needs for those mechanically ventilated and sedated, and neuromuscular paralysis can decrease the energy requirement by as much as 30%. Calculated results are only as accurate as the variables used in the equation. Obesity and restricted water weight complicate use of these equations. It has been observed basically that obese patients should receive 20 to 30 kilocalories per kg IBW per day, as well as use of adjusted body weight in those weighing more than 130% IBW, which is the ideal body weight. Predictive equations have been developed to account for obesity using actual body weight as well as trauma, burns, and ventilatory status. Protein requirement, dietary protein is required to build new and maintain existing body tissues and has many functions in the body. Protein can also be oxidized directly for ATP and is critical to the body's ability to perform gluconeogenesis. Protein is an important energy substrate to its role in tissue building and repair. Protein requirements in the surgical patients are elevated, especially in the critically ill patient. Increased requirements are the result of the need for tissue synthesis and wound healing, maintenance of pressure, adequate blood volume, maintenance of immune functions, and energy substrate. Stressed critically ill patient require protein in the range of around about 1.5 to 2.5 grams per kg per day. Achieving positive nitrogen balance is nearly impossible immediately after metabolic insult. But after the primary deprivation is controlled or resolved, positive nitrogen balance is visible. Protein requirement do not decrease with increasing age. Short-term inadequate protein intake in older adults has been changed skeleton muscles level that may lead to the muscle wasting. Reduction in lean body mass and loss of protein during the physiologic stress increase the protein requirement for critically ill older patients to requirements which is similar to those for younger patients. Protein tolerance, as opposed to protein requirement, often determines the amount of protein delivered. Water is the medium within which all system and subsystems functions. It is necessary in digestion, absorption, transport, and use of nutrients, as well as elimination of toxins and waste products. Total body fluids can be compartmentalized into two reservoirs, intracellular and extracellular. The, the intracellular compartment includes all water within the cell membrane and provides the environment for the metabolic reaction that take place in cells. The extracellular compartmental water includes all water external to cell membrane and allow nutrients to flow into cells and cellular waste products to return to the bloodstream. Water also provides structure to cells and is a vital component of the thermoregulation. Water is the most abundant substance in the human body, accounting for 60% of the body weight of man and 50% of body weight of women. The majority of water intake comes from ingested fluid and food. A small amount is produced as byproduct of metabolic processes, carbohydrate metabolism, which is the example of metabolic processes, byproduct of metabolic processes. The main source of water loss is in the form of urine. Sizable amounts are all lost insensibly through the skin and respiratory tract. Smaller amounts of water are lost in sweat and feces. Normal body water requirement can be estimated using a variety of methods. Its recommendation is 1 ml per kilocalorie energy expenditure for adults with average energy expenditure living under average environmental conditions. Fluid requirements increase with several conditions, including fever, high altitude, low humidity, profuse sweating, watery diarrhea, vomiting, hemorrhage, diuresis, surgical drains, and loss of skin integrity. Fluid balance is of vital concerns after surgery. Patients receive large volumes of fluid. These volumes are eliminated post-operatively, but the patients may require diuretics to facilitate this. Surgical patients is resumed and tolerated to maintain the fluid balance. Daily weight measurements of the patient provide a guideline for fluid balance. In vitamin and minerals requirement, adequate levels of vitamins and minerals are very important for optimal post-operative recovery. Vitamin C serves many functions in the body. In addition to being an antioxidant, it is required for synthesis of collagen, which is the structural protein found in skin, bone, tendon, and cartilage. Carnitine and neurotransmitters, as well as for immune mediated and antibacterial functions of white blood cells. Vitamin C is also required for the scar tissues, which aids in wound healing. Iron is essential component for the hemoglobin, which is necessary for oxygen transport, myoglobin, which is necessary for muscle iron storage, and in cytochromes, which transport electron through the respiratory chain, resulting in the oxidative production of cellular energy. Vitamin K is essential in the blood clotting by activating multiple inactive clotting factors, resulting in the formation of fibrin. Surgical patients with elevated enteric losses are at risk for several trace element deficiencies, especially zinc and copper. If losses exceeded 800 ml per day, then extra supplementation of micronutrients should be considered. Various GI operations may also place a surgical patient at risk for several micronutrient deficiencies, which is depending on the amount of remaining small intestine, the location of bowel resection, and the functional status of remaining GI tract. The preferred route of nutrient delivery is for the patient to be able to consume adequate nutrients through an oral diet. The majority of surgical patients can accomplish this by post-operative day 7 at the latest. Routine intravenous fluids are intended to provide hydration and electrolytes, not energy and protein requirements. For example, 1 liter of routine intravenous fluids of a 5% dextrose solution provides 50 grams of dextrose with an energy value of only 170 kilocalorie. No protein is provided. If adequate calories and proteins are not consumed, then the patient's diet may be supplemented. Often, the addition of between meal feeding that consists of soft high protein food is adequate. Sometimes commercially available oral supplements may be provided because they are a concentrated source of energy, protein, and vitamins minerals. Not all patients tolerate these supplements because they tend to be very sweet and patients develop taste fatigue. Every effort should be made to maximize the patient's diet for diet preferences to improve inadequate dietary consumption. A diet order is typically prescribed post-operatively once the patient exhibits adequate bowel function. The first diet order is a clear liquid diet, which includes hyperosmolar fluids, calories from simple sugars, very little proteins, and a fair amount of sodium and chloride. Because this diet is incomplete and very unpalatable, patients should be advanced to either a full liquid or soft regular diet as soon as the clear liquid diet is tolerated. These diets are complete diets in that calorie, protein, and vitamin mineral requirements can be met if adequate amounts are consumed. This historical diet progressions after GI surgery is basically challenged. Patients randomized to a regular diet as their first post-operative diet after abdominal surgery had equal tolerance and improved nutrient intake compared with those receiving a clear liquid diet. If an oral diet is not tolerated or feasible, then enteral or parenteral nutrition may be provided. Enteral nutrition is indicated for patients with an adequate functional GIT tract and oral nutrient intake that is insufficient to meet the estimated needs. Enteral nutrition maintains nutritional, metabolic, immunologic, and barrier functions of the intestines. It is less expensive and safer than parenteral nutrition. Parenteral nutrition administered 7 to 10 days before surgery decreases post-operative complications by approximately 10%. Wound healing and surgical recovery may be impaired if parenteral nutrition is not begun within 5 to 10 days after surgery in the patients unable to eat or tolerate enteral feeding. Enteral nutrition is the preferred route of nutrient delivery. It is not innocuous. Some situations exist in which enteral nutrition is not feasible, and parenteral nutrition should be used. Expected length of therapy, clinical condition, risk of aspiration, and medical expertise usually determine route of administration and type of access for the tube feeding. Multiple methods for obtaining the enteral access exist, all of which methods carry various levels of required expertise, risk, and expense. Nasoenteric or Orenteric tubes are generally used when therapy is anticipated to be of short duration, that is almost less than 4 weeks, or for interim access before placement of a long term device. Long term access requires a surgically placed feeding tube. The majority of postoperative surgical patients can tolerate a standard enteral formulation that provides their energy and protein requirements. These formulas are supplemented with various immune enhancing nutrients, including arginine, glutamine, omega 3 fatty acid, nucleic acid, and various vitamins and minerals. Nutritional concerns for patients undergoing alimentary canal surgery. The digestive tract is a metabolically active organ involved in digestion, absorption, and metabolism of many nutrients. Various surgical interventions involving the GIT tract can result in malabsorption and maldigestion and nutritional deficiencies. In head and neck surgery, patients present for surgery malnutrition because of their risk disease state. Many times, surgical interventions is required because of a tumor that may be inhibiting the patient's ability to chew and swallow normally. Loss of this ability is what makes the patient seek medical attention. Patients with head and neck cancer usually have a long history of alcohol and tobacco's use, which may also affect optimal nutrition status. Depending on the patient's treatment, optimization of nutrition preoperatively is ideal. This also depends on the individual's disease progression and ability to swallow. Many times, preoperative treatment involves radiation, chemotherapy, or both to reduce the tumor size. The ability to swallow in basically in these situations, specific situations, may worsen because of the negative side effects of these therapies. Placement of endoscopic gastrostomy feeding tube can be performed to allow for nutrition, hydration, and medication administration to maintain or improve nutritional status preoperatively. The patient may also still be able to swallow food, soft food, or liquids, which should be maximized for calorie and protein density. Several medical conditions affecting the esophagus can prevent swallowing and nutrient intake. Common conditions include corrosive injuries and perforation, gastroesophageal reflux disease, and partial or full obstruction caused by cancer and congenital abnormalities. These conditions usually require surgical interventions involving removing of a segment or the entire esophagus. The esophagus tract is replaced with either the stomach or the intestine. A gastric pull-up procedure involves drawing the stomach up to the esophageal stump. The colonic and jejunal interposition procedure involves forming a new conduit by the anastomizing the selected portion of bowel. Preoperative nutrition for these patients may be a tolerated oral diet. If a patient is unable to consume full nutrient needs orally, then a feeding tube may be placed if the esophagus is not obstructed, if the tube is not indicated, if a gastric pull-up procedure is to be performed, because the stomach is used to make the esophageal conduced and a hole resulting. For the patient with the chronic GERD, this is the most commonly performed entire flux procedure operations for the patient with gastroesophageal reflux. A number of nutrition problems may develop after gastric surgery, depending on the type of surgical procedure and the patient's response. Several indications exist for gastric surgery, including tumor removal, ulcer disease, perforations, and hemorrhage. A vagotomy is often performed to eliminate gastric acid secretion. Vagotomy at certain levels can alter the normal physiologic functions of the stomach, small intestine, pancreas, and biliary system. Total gastric and truncal vagotomy procedures impair the proximal and distal motor functions of the stomach. Digestion and emptying of the solids are retarded, whereas emptying of liquids is accelerated. These vagotomy procedures are accompanied by a drainage procedure that helps the stomach to empty. Nutrition complications associated with vagotomy and pyloroplasty include dumping syndrome, steatorrhea, and bacterial overgrowth. A total gastrectomy involves removal of the entire stomach. A storage reservoir may be created using a section of jejunum. A subtotal or partial gastrectomy involves removal of a portion of the stomach accompanied by a reconstructive procedure. A gastroduodenostomy involves an anastomosis of the proximal end of the intestine to the distal end of the stomach. A gastrojejunostomy involves an anastomosis of the stomach to the side of the jejunum, which creates a blind loop. Any gastric surgery carries some potential for development of malnutrition. Common consequences include weight loss, dumping syndrome, malabsorption, anemia, metabolic bone disease. Dumping syndrome, epigastric fullness, nausea, and vomiting occur in the postoperative period. These symptoms are managed with dietary modifications and enzymatic medications. Generally, after gastric surgery, small, frequent oral feedings are resumed according to the patient's tolerance. For the first 2 weeks after surgery, soft, bland foods with a low fiber content should be consumed in small portions. Small sugars, simple sugars, lactose, and fried foods should be avoided. Beverages should be consumed at least 30 minutes before and after meals, and foods high in complex carbohydrates and protein should be emphasized. These diet modifications are necessary only for the short term because most patients can resume a regular diet. Some individuals may need an anti dumping diet indefinitely for the individuals who were malnourished preoperatively. A small bowel feeding tube may be placed intraoperatively. Low rate enteral feeding using a standard formulation may be initiated on Post-operative day 1. Tube feedings are adjusted according to the patient's clinical progress and tolerance of an oral diet. Patients may be discharged home with nocturnal tube feeding until their oral diet consumption is optimal. Oral supplements may be provided to increase nutrient intake. They need to be isotonic, containing no simple sugars to avoid dumping. Most oral liquid supplements are hyperosmolar, containing simple sugar, and are not well tolerated after gastric surgery. Parenteral nutrition is indicated only if enteral access is not available and the patient is malnourished and not able to tolerate adequate nutrients orally. Anemia is common consequences of gastric surgery. Anemia can be attributed to a deficiency or malabsorption of one or more nutrients, including iron, vitamin B12, and folate. Assimilation of vitamin B12 requires liberation of the vitamin from protein and binding of the vitamin to intrinsic factor, both of which occur in the stomach. Failure of either of these reactions to occur results in vitamin B12 malabsorption, which with time procedures anemia. Total gastrectomy patients require periodic intramuscular vitamin B12 injections. Metabolic bone diseases can be a late complication of gastric surgery. The cause of metabolic bone disease varies with the surgical procedure. Procedure is associated with more complication because it bypasses the duodenum and upper jejunum. Procedures that destroy the pylorus can result in rapid gastric emptying, which may contribute to development of metabolic bone disease. Rapid gastric emptying not only reduces the absorption time but also, when fats are malabsorbed, can lead to the formation of insoluble calcium soaps. Fat malabsorption can also lead to vitamin D malabsorption, which leads to impaired metabolism of calcium and phosphorus. Surgical resections of the small and large intestines are usually well tolerated. If excessive amounts of bowel are removed, then nutritional consequences can arise, dependent on the location resected. If more than 50% of the small intestine is removed, then short bowel syndrome may occur. This syndrome is characterized by severe diarrhea, osteoturia, malabsorption, and malnutrition, depending on the amount of remaining small intestine, the site of the resection, and the functional status of the remaining GI tract. The patient may require long-term parenteral nutrition to maintain his nutritional status, fluid and electrolyte balance. In case of duodenal and pancreatic malignancies, pancreatoduodenectomy may be performed. This procedure, one of the most difficult and technically demanding in GI surgery, involves resecting the distal stomach. In case of intestinal lesions, obstructions, or inflammatory bowel disease of the entire colon, or when diversion of fecal matter is required, an ileostomy or a colostomy may be the treatment of choice. These procedures involve creation of an artificial anus in the abdominal wall by incision into the colon or ileum and bringing it out to the surface, forming a stoma. A pouch is placed externally over the stoma to collect the fecal material. Patients with ostomies should eat regular diets. Foods that are gas forming or difficult to digest may be avoided to reduce the undesirable side effect. In the case of high output osteomasis, which is usually more than 800 ml per day, patients may need to avoid hypertonic, simple sugar containing liquids and foods. fatty foods, and foods with a high amount of insoluble fiber to reduce output. Surgery for the treatment of obesity has become more prevalent in the past several years. Probably that most common procedure for weight loss in the world is the vertical banded gastroplasty, a gastric stapling. This technique is performed under general anesthesia and requires about 4 to 5 days in the hospital postoperatively. This procedure limits the food intake by creating a small pouch, which is half ounces, in the upper stomach with a narrow outlet, which is half inches, reinforced by a mesh band to prevent stretching. The pouch fills quickly and empties slowly with solid foods, producing a feeling of fullness. Overeating results in pain or vomiting. This procedure is preferred for those people who engage in bulk or binge eating. The disadvantage of this procedure is that weight loss is not as great as that with other procedures. It does not restrict the intake of high calorie food liquid, and the pouch can stretch with overeating. As a result, 20% of people do not lose weight, and only half of the people lose at least 50% of their excess weight. Like any major abdominal operation, these bariatric surgical procedures carry risks such as bleeding, infection, bowel blockage because of the scar tissues formation, hernia through the incision, and the anesthesia risk. The most serious risk is leakage of the fluid from the stomach of intestine, which can result in abdominal infection and reoperation. Additional risks are directly related to the being obese. These include blood cells in the legs or lungs, pneumonia, and cardiac complications. Less immediate risks are ulcers in the stomach or intestines, dumping syndrome, obstructions of the stomach, and malnutrition from too rapid weight loss and loss of vitamins and minerals. Patients with trauma and burns exhibit similar as metabolic alterations occurs to a much greater extent. Few traumatic injuries results in a hypermetabolic state comparable to that of a major burn. Understanding of the cause of metabolic response and implication for nutritional requirement is necessary with traumatic and burn injuries for a nutrition care plan digested to minimize the effects of hypermetabolism and hypercatabolism. Stress patients undergo several metabolic phases as a series of states reflecting a patient's response to the severity of the stress. Size and depth of the burn wound affects its healing process and overall prognosis. First degree burns involving cell necrosis above the basal layer of the epidermis. Second degree burns necrosis within the dermis. Third degree burns including the fat layers, full thickness skin loss. Burn patients require individualized nutritionist plan to provide optimal energy and protein to accelerate the muscle and protein synthesis and minimize the proteolysis. Numerous predictive equations are used to estimate energy needs. During the flow phase of metabolic stress, hyperglycemia is present because of the increased glucagon to insulin ratio that activates the gluconeogenesis. Tissue insulin resistance further exacerbates the glucose intolerance. Despite these metabolic aberrations, carbohydrates should be the primary energy source provided for the burnt patient. Lipid is an important component of a trauma or burn patient's diet for many reasons. At 9 kilocalorie per gram, it is an isosomatic, concentrated energy source for these patients. Dietary lipid is also a carrier for fat-soluble vitamin as well as a provider of the essential fatty acid linoleic and linolenic acid.